Thank you, Vanessa, and Julia and Dr. Fisher for speaking beforehand and giving the background to this whole project that we've been so fortunate to be involved with. So, I won't keep this up very long. As Vanessa has mentioned, the cardiac rehabilitation team for the Royal Liverpool and Broad Green Hospital sites were approached and invited to come along on the journey of this Lipid project. And of course, we were very enthusiastic and highly honoured to be given such an opportunity. Because as we all know, when services are very stretched and so on, you know, opportunities can be very few and far between. But because we were so excited by it, you know, we were really determined to make it work as well as what we could. So we can see the names up there of the different people involved. As we say, highly fortunate to be working with such specialists, Dr. Mishra, Prof. Fisher, Dr. Bennett. Of course, we had the wonderful involvement from the pharmacists, which although we linked in with them previously in our role generally, we were just more fortunate to have more quality time with them. And then we went on to have some limited admin time given to us as well. So the basis and the background for this pilot has already been set by the speakers beforehand. To identify the cardiovascular patients and ensure that their lipid optimization was being managed as well as possible. And although, you know, things such as this should occur in primary care, for various reasons, we know this doesn't always happen. So again, you know, we were very honoured to be given such the opportunity. And obviously in our role in cardiac rehab, you know, we do deal with various aspects of lifestyle changes and so on, but to be given protected time as such set aside just for this one particular thing, you know, we were really, really interested in. Now, someone mentioned earlier that there may be some individuals who don't really see cholesterol, you know, as a key thing because it's not something they can always physically see in front of them. So again, that was where it was down to us to use our skills and powers to try and educate patients and motivate them a little bit more as well. Oh, sorry, you don't want to see that again, do we? So again, as we say, Vanessa's already, you know, set the scene. How did we do it practically on a day-to-day level? So because of the likes of the pandemic and so on, we conducted retrospective audits of known patients to us, and then we separated them into various groups: STEMIs, non-STEMIs, angina and CABG, and we placed them into 3 cohorts. So when this started out, we were speaking sort of quite separately, but very quickly we all came together to conform an MDT, and that went from weekly to alternate weeks. And this was a wonderful experience as well for any teething problems and just support to all the different staff involved in forging this pathway ahead. It's the same now, isn't it? Okay. So, as mentioned, we looked at the patients known to us, and we then separated them into 3 different cohorts. So the ones who, you know, post-event were still not on a statin or any therapy. The ones who were on a statin but had no repeat bloods taken. And again, as mentioned, the pandemic played a massive role in patients not being able to access bloods and so on. And then there were the patients who, you know, were on the statin but had never been reviewed, etc. So not only did we not know how effective their treatment was being, but also from a patient perspective, they had no way of marking their own progress and to keep them motivated with either the lifestyle changes or the medication compliance as well. So out of those cohorts that we separated, in total there were 259 patients that we identified and who we then went on to contact and invite them in. So we initially, again, due to lack of resources at the time, we sent an invitation letter with an appointment to them, explaining the whole aim of the project and blood forms and a cholesterol booklet as well. And then we would book them in to come for their initial consultation. And then after that initial review, we would then decide whether, you know, they would have repeat follow-ups with ourselves, back to the GP, or as Dr. Mishra mentioned, back to the lipid specialist clinic. So because of a few various initial delays, that clinic was actually rolled out in May of last year. And as Dr. Mishra's already shown us, there was a lot that went on behind the scenes just to get to that point. So the patient was invited in, and then, as we say, depending on the outcome of the assessment and so on, it would be whether they would then need another face-to-face appointment or virtual or telephone follow-up. The GPs were also contacted along the way with any changes, etc. So, typical patient consultation, past medical history, lifestyle and risk factors. We would also demonstrate with our A&P models that we have in the department, which we always do with every patient's assessment anyway. Body mass index, and then the clinical examination for the clinical signs. And then the Simon Broom or Dutch lipid score as well. These are all tools that we use during our consultation to determine the next step for each patient. Dr. Mishra went in depth before talking about the lipid passport given to the patient. And again, as a project, the whole team felt that this lipid passport was highly, highly important, both to staff and to the patient. Now, there are numerous lipid passports across the country, and you know, many of them do. We felt that it was also giving the patient some ownership over their own condition, their own lifestyle, and going forward. And if you can help them chart the progress that they're making, will in many cases enhance their compliance. And also, given them their non-HDL targets, it just gives them a little bit more of a goal of what they're aiming for. The other benefits of the lipid passport was it just gives the patient a focal point, name, contact details, etc. And we also had other information on a Happy Heart website, as well as the BHF websites that we tell all our patients of too. And again, some of these patients will have brought relatives with them to their appointments or over the phone. So there were times to enhance the information given out to them as well. So as a team, we were then introduced to REDCap, which was the national database. As we know, with every service, we always want facts and figures, outcome measures and so on. But we also worked closely with the Innovation Agency to get some local data that was required. And I have to say, the Innovation Agency were so helpful and supportive throughout this whole process. Anything we felt we wanted or needed, we literally just liaised with them, and you know, in time that was brought our way. So thank you very much for that. Also being mentioned is the Deontics electronic pathway, which we were very excited to hear about this. because of the data it would exchange and collate, and it will be a useful tool and will definitely speed up that data collection that we need and transferring. And also patient satisfaction questionnaires, which my colleague Lorraine is going to talk about with patient feedback with Mark. So just a few basic figures here. Out of the different cohorts, we found that there were 36 not on a statin. As suspected, there were 154 that had no repeat bloods to gauge any progress. And then there were 69 on a statin, but again, targets were still not being reached to an optimum level. So out of the 259 patients we identified, 151 of them were actually seen face-to-face and then would have been offered follow-up appointments, whether virtual or face-to-face as well. Now, some of the reasons for the full 259 patients not being seen face-to-face would have been if they were unwell with other events or if they declined the appointment. As we say, you know, perhaps because of COVID or DNAs, as Lorraine says. Many patients were still very sceptical of coming near the hospital and very honoured to have been offered this opportunity for the patients for the Royal Liverpool and Broad Green Hospital. And although it was quite a rollercoaster journey along the way, what we found worked well was the enthusiasm by everybody within the team to give this an absolute best shot and make it work as well as what we could, despite the ongoing difficulties that everyone is aware of with the pandemic, you know, low staffing levels or patient perception and so on. I mentioned before about the support from the Innovation Agency, that they were just wonderful. You don't have to email or phone with whatever, you know, the query or the issue was, and they'd have it dealt with very, very quickly. Again, you know, we were all just so enthusiastic about making this work well. I think from a practitioner level, we found it really useful to work closely with Marge because, as I say, at the beginning, we were told that wouldn't be the case, but for many months we did. And it was just a massive learning curve for the three of us. We all learned so much from each other. The patient experience now, Lorraine will talk more about this in a little while. It was a little bit mixed, as we say. There were some patients who were still, you know, very nervous about coming to the hospital, but equally there were many patients who were just absolutely thrilled and delighted with the opportunity to have a face-to-face consultation with someone at the hospital and their relatives as well. So that was really rewarding both for the patients and the staff involved. Again, on a day-to-day level, the introduction of the point of care testing machine was just more or less life-changing for us, wasn't it? And again, from a patient perspective, they found that really much more user-friendly than having to go to, you know, perhaps a different part of the hospital to have bloods taken. Now, again, for quality control purposes, we did liaise with the labs as well, just to ensure that, you know, anyone who initially was having points of care, we did actually have a small number of them agree to have regular bloods taken as well for quality control purposes. Now, throughout this whole project, the electronic lipid pathway was reviewed and altered many, many times because of clinician feedback and so on. So that was more or less finalised just towards the end of the project. And it will be an absolutely wonderful tool to utilise, won't it? And will certainly make the day-to-day working life of clinicians much more smoother with a quicker transfer of data and information as well. So, lessons learned. During this process, there was a bit of media, to say the least, about new cholesterol management treatments available. So we did have some patients who would just phone us up and say, oh, I've heard there's a new injection. Can I just come and have that? You know, obviously not understanding that there's steps to go through and so on. So obviously that was for us to use our powers to try and clarify those things. But again, this is what the media does. Sometimes it gives out really good messages and other times it doesn't. I think one of the biggest things that everyone underestimated at the beginning of this project was the amount of time behind the scenes taken to identify patients, contact them in advance, get the blood forms out in advance. Again, during this, we had the blood bottle shortage that impacted as well. So that was a definite thing that we took away, and we did eventually get some extra admin time provided to us, which we still didn't feel was quite enough, but definitely smoothed things out. But I think we all agreed it was definitely the biggest thing. If the patient appointments could be sent out in advance time, it would reduce some of the DNAs, not all of them, but some of them. So again, that increased admin support really helped us with that.
We had the introduction of text messages as well, near to the end as well, which helped with to prevent some DNAs as well.
Yeah. Like we say, the point of care tester machine, although it was wonderful, sadly, a bit like the electronic pathway, that only came in towards the end of the project. So going forward, you know, if we'd have had that much earlier on, would have just made things a little bit easier.
We would have been able to see more patients as well if you'd have had the point of care at the beginning.
But equally, we were just grateful to get it at all. And again, as we say, in going forward, which hopefully things will, the electronic pathway will definitely smooth things out. So I don't know if the questions are being answered at the end, Venetia, or at this point.
Okay, so there's a question here. It is from Sharon Faulkner to everyone. You mentioned 36 patients were not on statin in cardiac rehab. What was the reason for this? As all eligible patients would be discharged on a statin, apart from probably delayed liver function test.
Okay,
that's clear.
So Sharon, some were non-compliant for the start, and then what was the other reasons why, Joe? I can't remember.
Some of them were non-compliant, as you say, for what they perceived were side effects, etc. And again, you know, there were discussions held over how frequently they were taking the medications, what time of day. And again, this was one of the many things that we learned working with Venita. You know, you can be a lot more flexible with the patients. For some patients, it suited them to just take alternate days, and then any side effects may have reduced and so on. For some patients, they had not received a repeat prescription, so therefore didn't think that they needed them. They were the main reasons that we came across.
I mean, obviously there was a few with deranged LFTs and things like that, so that's why they weren't on the statin either.
Yeah, and with the deranged LFTs, some of them had had problems getting repeat bloods, as we say, because of the pandemic or the blood bottle shortage and so on. Hope that answers your question, Sharon.
I've just had another comment here from somebody who said that looking at the data, about 50% of patients are discharged not on a statin.
50%, yes.
So that doesn't.
And again, I know we've worked very closely, obviously, with the Royal Liverpool Aintree and Liverpool Heart and Chest, and the medics are normally very good trying to ensure that. But obviously, we're talking nationally as well as locally on.